Welcome back to Clinical Communication. Today I'm speaking with Ian Reilly, who is a consultant podiatric surgeon and international speaker. Today we're discussing communication around bunions, toe deformities, and management options for them, including surgery. You can find both Ian and I across social media and online, and I'll put the information in the description for this episode. If you have questions or situations you want help with, or stories you'd like to share, you can now also send it into clinicalcommunication@outlook.com. Again, is in the description, and they'll be read out and answered for you. If you find this useful, please do go and share it with others. Please do subscribe and tell us what will make it better. Thank you for watching or listening, and I hope you enjoy, and I'll see you next time.
And interestingly, when he came out of the restaurant,
Yeah.
there was a busker
Yeah.
playing Waterloo
Yeah.
and Mamma Mia on a didgeridoo. And I thought, do you know, that's Aboriginal. There you go. You're getting the
I'm getting
tempo.
there
Brilliant.
now. I'm getting this
Brilliant.
now.
We'll get there.
These are the dad jokes that my children are much younger, so I'm still getting into the swing of them.
Yeah.
And
Yeah, well, I've been a dad for a few years, so dad jokes are my thing.
my wife even had to buy me a book of bad dad jokes last year just to help me along a bit.
Yeah, yeah. Do you know when a dad joke becomes a dad joke, Ben?
When you become a dad?
When it becomes apparent.
This
I
is the
mean, I
most
can do this
comedy
all
this has
night.
ever
I
had.
can do this all night. Not even without any trouble at all.
That's been the best start anyone's ever had. That's great. Thank you for doing this, Ian.
Welcome,
And
welcome.
um, and from different countries as well. You're currently in
Yeah,
Romania at the moment.
currently in Romania. It's 9 o'clock at night. No, it's not. What time is it now? 9:30 at night,
It's
isn't
nice.
it?
Although with a better connection I've had with people in the UK,
Yeah,
ironically.
my in-laws have got really good Wi-Fi, to be fair. So it's yeah, it's kind of nice. The kids are all asleep. I think my family are just sitting down to a late dinner. It's Christmas is kind of a big deal over here. So we've just had the neighbours visiting. You know, still get carolers. You know, Christmas is really good in Romania, and lots of booze.
You were telling me it's very it's similar to British, just more alcoholic. Is that right?
Yeah, but it's also kind of more traditional. You know, it's normally we were supposed to have snow today, so it's actually not been a white Christmas this year, but it often is.
Mm.
You know, lots of family, lots of extended family, lots of godparents. It's quite a not quite. It's a very religious country in terms of Orthodox Christian. So the church is very big. Hence, kind of Christmas is very big.
And
And while
do they kind of, because in the UK, once Boxing Day ends, everyone kind of moves on. Is that the same there, or do they still kind of celebrate it for the days afterwards?
Yeah, so the Christmas is kind of effectively a 3-day event,
Mm.
but then runs into kind of the New Year. So they just kind of everything's just kind of larger, kind of like it would have been probably like 50 years ago in the UK. Really, I mean, I probably shouldn't tell them that it was only in the fourth century where Christmas Day was agreed to be Jesus's birthday, and lots of these things have been post revision by the church. But I have to keep off religion with family because we're of a slightly different persuasion.
Right. We're going to talk about the communication with specific podiatric surgery topics today.
Cool.
Um, and and I say with all of these in advance, we're talking about the communication around certain aspects of them.
Yeah, yeah.
Not so much on the clinical reasoning or specific treatments. Ian has courses for that and plenty of social media stuff people can go look at. Ian, you told me before I hit record, I think, you've wanted to do feet since you were 11.
11 years old. Yeah.
Most people, I was talking to my wife about this beforehand. The idea of working with feet every day would, I'll be honest, repulse them. But what was it about feet that from 11 that made you want to do it for the rest of your life?
Um, so the kind of the glib answer is because my mum was a chiropodist.
Okay.
So there are how many there's in the family? Well, podiatry now. So, but when I trained, it was chiropody. So I trained 85 to 88, and it was chiropody. Then it became podiatry sometime around 2000, I think. So my mother was a chiropodist. One of the cousins was a chiropodist. My brother and I, we both became chiropodists, and we both married chiropodists.
Oh, really?
So technically, there are 6 in the family. So it was kind of like the family business. And my mum used to work from home, so my earliest memories are just seeing feet because she used to work from home. Just her clinic was in the front room at home. You know, wander in and somebody's feet would be on her knee. So it just seemed the kind of the natural choice for me to kind of go into the family business, really.
And when did you become a podiatric surgeon?
So qualified as a chiropodist in 88, and then knew right from then I wanted to go into surgery. At the time, it was called podiatry when there was chiropody and podiatry. And so I went straight to a unit where they were developing a podiatry service, which was Ipswich, and kind of had to wait my turn to get trained. So in 92, I started training. And at the time, it was a 4-year course. So it was 92 to 96 was my training. It's now a 9-year postgraduate course. So I actually, carried on training after I'd got my theoretical tick in the box. So at that point, really, chiropody become podiatry. So podiatry became podiatric surgery.
And doing that
Oh,
ever since?
yeah, yeah. So, well, yeah. So 96, I kind of qualified in podiatric surgery. And at the time, I was struggling to get a job. I'd actually fallen into management. So I was actually managing a podiatry team. So I spent 6 years in management,
Mm.
thinking that I might kind of go down the management route, and then realized actually I still enjoyed the clinical side more than management. Then couldn't quite get a full-time surgery gig. So I moved to Northampton in 2000, which had a small surgical service. But I was a lecturer. So I became a lecturer in podiatry, which was effectively 4 days a week teaching and 1 day a week doing surgery. And managed to kind of build up the surgery, and a couple of false starts later, I think probably from 2004, yeah, I kind of moved that surgical service into the NHS. And so really I've been a full-time surgeon for 21 years, 21 years. So
Still,
part-time from 2000 and then full-time from 2004.
and still enjoying it?
Love it.
Grand,
Absolutely love it.
grand. So we're going to talk about, obviously you cover a wide range of things in podiatric surgery. We're going to focus on two today,
Okay.
and around them. First one is around something you see a lot of, which is bunions.
Yeah, yeah,
Now, most people listening to this, I'm sure, could picture what a bunion looks like. But if I ask them to say anything else about what a bunion is or what it means, they probably go, don't know.
yeah,
And I'm thinking, I mean, I've seen people after bunion surgery for their getting back on their feet in their rehab.
yeah.
Um, but let's say we've got 60-year-old Trisha who's
Yeah,
sat down with the healthcare professional and says, "What's this
yeah.
on my big toe?" The clinician can work out it's a bunion after discussing it with her. What should we say? And if she asks, "Why have I got this?" What do we say?
Okay. So the answer is it's multifactorial. Now, for those people, we kind of talking about biomechanics 10 minutes ago. So the biomechanics would talk, certainly the Americans would talk about excessive subtalar pronation, so flat-footedness. And I do think, because I was trained in roots, it's difficult for me to get beyond people that overpronate, put more pressure onto the big toe, and you'll get a hypermobile first ray that then becomes a little bit unstable. So I do think that the majority of the bunion patients I see are a bit flat-footed. So I still think that's probably the biggest thing out there. In the mix, you would throw in around metatarsal head, you'd have to throw in heredity, you'd have to throw in footwear, but they're all a mix. And I think probably the thing with all of those things, it kind of would make, so like with heredity, I think you have a certain function because of the shape of the foot. I think that's how that kind of works. I've not looked at the studies for a long time, but I remember reading years ago that the unshod races of the world still get bunions, but those that particularly, I think there were some big studies done in Japan years ago when Japanese ladies went to a Western style shoes, that their incidence of bunions kind of rocketed. So I think shoes would make a bunion much quicker. But if pushed, I would say that probably flat-footedness is probably the biggest thing. But when you look in the books, and I was actually did a bunion lecture about 6 weeks ago,
Mm.
and it made me look at the evidence. Even the most up-to-date evidence kind of said, well, we're not really sure.
And if they say, "What is it?" What should we say?
It's a deviation. So a bunion effectively is a dislocated big toe. And
Oh.
it's amazing how often, Ben, I get patients sent through with a bunion. Actually, they don't have a bunion. Quite often it's arthritis. Sometimes it's gout. Sometimes it's
Mm.
kind of soft tissue thickening. But really, a bunion is deviated big toe. And the bunion itself is actually the bursal swelling that you'll get medial first MTPJ. So technically, the bunion is a soft tissue bump on a deformed mostly in the transverse plane, but you'll get some transverse and some frontal.
Mm.
Because technically it's hallux abductovalgus. You'll get abduction, abduction, and valgus rotation of the hallux with a soft tissue thickening.
Mm.
So the bunion technically is the bump, but
Okay.
on an angulated big toe. So
Mm.
you'll get patients come along, and effectively the bunions hurt for three reasons, really. It's either the bump, which is a shoe irritation issue. It's either the joint being a bit dislocated, so effectively it predisposes to arthritis in the joint. Very, very often, even in 20-year-olds, I'll open the joint up and you'll see the arthritis already at play.
Really?
Or for sure, 20, 25-year-olds, open them up, you've already got a little bit of medial wear. Or you'll get pain in the sesamoid, which is kind of less common. So patients come along with typically pain,
Mm.
but also there'll be an element of cosmesis in that for my female patients more, as in they don't like the look of it, which I fully understand. And there'll be an element of footwear fit within that. So it'll be pain, difficulty with footwear, and a cosmetic. And then it's trying to pick out of that what is it that's the main issue, and then how do I best address that as a simple surgeon? Am I the right person for them, or do I need to send them to kind of a footwear guy to make them have shoes that fit,
Mm.
or do I need to send them to insoles to help with their function?
Yeah.
I think quite often they will end up back at my door because I think sometimes they need a fix. But
Mm.
I'm not gung-ho with surgery at all, because I can absolutely make somebody's foot worse with surgery, and have done on a number of occasions. And these things wake me up at night and kind of haunt my dreams. Genuinely,
Really?
regularly lose sleep over patients that haven't done well or aren't going well. And I think that should be the case for all surgeons.
I think that's something we often underestimate as non-surgeon healthcare professionals is, you know, it can be the downsides can be drastic.
Mm.
The risk that's involved, um, you know, someone comes to see not just physio, osteo, chiro, OT, whoever, they may not get better, but very rarely are we going to cause them something that is lifelong, make them worse in the majority of times. I know, obviously, most of the time surgery goes to plan, hopefully, but
Yep.
of course, it can be. You said it can be catastrophic at the other
Yeah,
end
yeah.
as well.
Yeah. I kind of reached a bit of a milestone. We have to keep a surgical log of everything we do, and I reached a milestone last month of 3,000 bunions and 4,000 hammer toes in the same week, which was quite lyrical, I thought. Um, that's my cases, and that's including my trainees. So I log all the cases that I did with my kind of previous trainees. But I can tell you, I've had 4 patients that have lost hammer toes, and I can tell you everything about those 4 patients, Ben.
Yeah.
How the surgeries went, how they didn't go well, and in um, 3 of the cases out of 4, it was my fault.
Okay.
I pushed it and tried too hard to kind of overcorrect things. One of them was just bad luck. So yeah, 10% of the time we'll have a problem, and so that can be, in terms of any surgery, I always talk about a 10% complication risk. So that can obviously be, 2% risk of infection, 0.5% risk of a DVT. Had a really bad VT actually in a patient this year, and she's very systemically unwell at the moment. Really big lung clots after a bunion surgery.
Wow.
Risk of non-union, risk of poor position, risk of pain, risk of arthrosis, risk of metalwork failure. And I've seen and caused all of these, and it's really tough. Most of the time, as you say, patients do well and are very thankful, and it's hugely rewarding. But I tend to remember the ones that didn't go well. They're the ones that kind of wake you up at night and think, yeah, didn't go well. And many times it's not me. Many times it's bad luck. I mean, infection is just one of those things.
Mm. And those
Yeah,
infections,
it's a pressure. It's pressure.
yeah, definitely. The infections, the DVT, they would all come after, right? They're not going to happen there in the room in front of you. Is that right?
Just so. Although, I went through a phase of doing quite a lot of diabetic foot surgery. So you'll see patients who are coming with an infection. So you're doing, I don't do the big limb salvage, but I've certainly done my share of, amputations and,
Mm.
management of infections, incisions and debridement. And that's even more scarier because you're dealing with a foot that's probably going to die and fall off if you don't do something, and you're looking for a kind of a best guess. But yeah, your average infection is going to come on 4 to 5 days post. Your average DVT. Do you know when your average DVT comes on after a surgery?
I'm going to guess somewhere in the 7 to 10 days.
Yeah, 30 to 35 days. So
Really?
yeah, it doesn't really show up for a little while, which is interesting, really. It's that kind of prolonged immobility, really. So, and those patients can obviously be very systemically unwell. And funny enough, actually, I've been involved in a big piece of work over the last couple of years. Managed to get tagged on to a big orthopedic piece of work, looking at. So we did a kind of a prospective study. It's called the FATE trial, foot and ankle thromboembolic disease. And one of the things we struggle with as a kind of a subgroup of surgeries is what are the relative risks for foot and ankle surgery, because the risks are kind of well defined for knee and hip arthroplasty, and we always knew that for foot and ankle surgery the risks were less. So we did a big 6 month prospective data gathering and found actually that the risks were a lot less for the foot, based around effectively our biggest risk factors would be Achilles surgery, prolonged immobility, 6 weeks in a cast. So we're able to kind of quantify that now. So it's nice to know that the risks in foot and ankle surgery are pretty small, but still on an average day, if I'm doing 6 or 8 cases on a surgery day, I'm probably prophylaxing, as in chemically, between 50 and 75% of my cases.
Just to reduce the risk.
Yeah. Because if we don't,
Mm.
and a clot ensues, then there's an argument there for, kind of a case for negligence. And I think because we actually manage them aggressively, big guidelines came out in 2010 that kind of changed the map for DVT, VT management. So I think we see a lot less because of that. So it's partly because it's the right thing to do, but also because if we don't, we're deemed negligent. So it's a bit of carrot and stick, really.
Yeah.
That's been interesting, because that wasn't something that, as a non-prescriber, which I was at the time, that was kind of difficult to access these drugs. And then I'm sure it's the same. You can become an independent prescriber with physio, can't you?
Yeah.
So
So as we're on the subject of risk,
yeah,
let's say this person, whether it is a bunion, whether it's a hallux, whether it's any form of foot surgery,
yeah,
or how should we explain the risks to someone? As you say, they're less than they used to be, but
yeah.
obviously they're still there.
Are we talking about VTE or general?
We'll say general.
Okay, so it's going to depend on the surgery you do. So you're thinking about bunion surgery, effectively you've got 3 classes of procedure then. You can either do what I call a bump and run, which effectively if you're just doing the bunion bump. So really just doing an exostectomy, excuse me. So just literally doing the bump. So that's pretty simple, carries the lowest risk. You've then got some form of osteotomy, so you're breaking and resetting the bone, or you've got a joint destructive procedure. So you've got let's take your 60-year-old patient. Now, at that point, it might be they've just got a bump problem. So you might just want to do the bump removal. It's more likely that they'll have some form of angular deviation. So you really would want to kind of break and reset. It might be that you've got end-stage arthritis with a bunion, in which case you look at a joint destructive procedure. 3 options for that: removal, fusion, replacement. So, you look in the kind of the lexicon of bunion surgeries, and you've got 130 different bunion surgeries in the literature.
Wow.
Yeah. So you've really got to kind of pick kind of what you think is the right technique for the right patient. And then obviously the more you do, the bigger the risk. So if I'm just going to just do a bump removal, you're not breaking and resetting, there's no hardware, you're not looking to completely change the mechanics, that obviously carries the lowest risks. If you're doing a joint implant, for instance, where you're taking out all the joint, reaming it out, so then you've got a big void, you then put in a little bit of typically plastic fantastic, typically we're using silicone, Swanson type implants is the most common at the moment, but there's metal out there, there used to be ceramic, there's all sorts of things you can use. You run the risk if that then gets an infection in, you then you quite possibly lose the toe and or half the foot, because you'll have a big void for an infection. So when you say the risks, they're all relative based on the surgery, But 2% infection risk is what we'd quote for clean surgery. But there's a difference between a small wound and it's just a bump, as opposed to if you get an infection in a big void, then that can be somewhat more problematic.
Right.
So yeah, I have long conversations with patients about risk all the time, back it up with information leaflets, but it's all tailored. So I have kind of set paragraphs that my secretary uses for my patients, and that she'll put in. So I do the audio dictation. So I'll have like a standard paragraph on risk for each patient letter, but then I'll tailor it for every individual patient based on what they're having, but also their particular medical history. So doing a 25-year-old bunion with good bone stock is entirely different to a 93-year-old, as my record, with osteoporotic bone and a history of Parkinson's. So you've got falls risk might be my biggest worry, for instance, or the bones collapsing. But it's a big part of my daily consults is saying, okay, this is what I'm going to try and achieve for you. This is, these are your symptoms. This is how I think with my limited skill set, I can make you better, pain, function, cosmesis. This is what I can do to try and meet your goals. But these are the specific risks for all those steps. And, it becomes a partnership, or it should be.
People talk about shared decision making all the time, right? About feeling informed, weighing
Yeah,
up the options.
yeah. And they have all this written down. So
Yes.
it's all there. They get everything copied, so they've got a cooling off period. And we work on a two-stage consent as well. So we do it,
Right.
start it, and then we finish it. They've got time to kind of take it all in.
So the first stage is there in the room
Yeah,
with you. The
yeah,
second stage is
on
that
the day.
later on with you again?
Yes, I mean there are some people who bring patients back pre the surgery, so they literally have two pre-op consultations. So I tend to do most of it on the first consult and then immediately on the surgery. But in between consults and surgery, they get a big wodge of information. So that letter, information leaflets, and that I think that's sufficient for most people. But I always invite people, if they're unsure, come back on a second or even a third time, because I can't really afford somebody to turn around after surgery. That's happened. So you learn from your bad experiences. When people say, "Oh, I never knew that." So, you have these over the years, you go, "Oh, okay." So my patient information leaflet, I've actually left the NHS when we're still in 2024. So I left the NHS after 36 years this year
Oh,
in full-time private independent practice, although ironically most of my work is NHS patients in the private sector. But my information leaflets that I developed while I was in the NHS, I got to about version number 41. So like my Bunion leaflet had version number 41. So I
wow.
started it back in 2000, first information leaflet.
Yeah.
And then you had experiences. Patients had bad outcomes. Patients had or typically more questions. I went, oh, that's a really good point. And so it went from literally a 2-page information leaflet to 12 over those years, when you'd see patients say, oh, what about this? And so I've got within my information leaflet, I've got section on smoking, section on DVT, gait, use of crutches, surgical aims, consent, anaesthesia, to try and cover everything. And you can tell patients too much. That's the thing.
True.
So in the consults, I'll concentrate on the things that I want them to remember. They've then got time to read everything. And then pre-surgery, I say, okay, let's go through the main things again, because you can't expect them to remember 27 different risk
No,
factors.
no. And I presume I'm making an assumption here. There would be some people who would read it in depth and go through every page,
Absolutely, yeah.
and there'd be some people who just glance at it.
Who
But
say, I don't want to know, just fix it. I trust you. Yeah. Yeah, which is fine,
yeah.
except if they come back 2 years later with a complication and say, well, you never told me that. So you've got to make sure you've provided information to them. So when they get a signed copy of all my correspondence and an information leaflet that goes through everything, and that's kept in the notes. So, and I've had to do that, on a few occasions when people say, well, I never said, well, funny you should say that. Here it is in the records. That, if you chose not to read it, it's not like you give them a test on the day of surgery, say, right now, list again the 47 different complications we talked about.
Yeah.
Because patient recall is clearly a thing.
Yes, I think it's don't know what the stat is, but it's, as you say, 20% ish of what we
Yeah,
say, if
on a
that.
good day. On a
Yeah,
good day. Yeah.
exactly. Um, as you as you were saying about it there, I'm thinking the more minor of the few surgeries you mentioned, if someone comes in to see you or a podiatrist for their
Yeah.
for their bunion,
Yeah. Yeah.
uh, and let's say whatever is done, whether it's a surgery or something that's done to correct it, and they say, will it come back again?
Yeah, great question. So I get that every week and pretty much mostly every day.
Okay.
So overall, we talk about, people will differ with the percentages, probably like a 5% recurrence rate,
Right.
over the course of a lifetime.
Okay.
I've certainly had um, patients of mine that have come back within 6 months, 5 years, and they've had some recurrence. And really, what I think is that basically the better you fix that joint, so the straighter you make it,
Mm.
the better it will function long term. Now, there will be some people who'll say that to prevent recurrence, you need an insole to kind of correct the mechanics,
Mm.
and that's not my view. I
Mm.
think that patients will still pronate on even the best orthotic. So I think the better you align the joint, the better it will function. That's my view. And I say that having looked at those of my cases where there's been some recurrence, and I've looked at my post-op X-rays. I typically X-ray at week 4, week 6, and if I look at that and kind of go, yeah, that was a little undercorrected, those will be the ones I think, yeah, that was perhaps I didn't get as good a fix on the day. Not all the time. I had a lady 2 weeks ago, and she's had fair recurrence over about 3 years, so it's about 50% back. She's still happy. We're not going to do anything to her, but I monitor her. And those post-op X-rays were perfect.
Mm.
And I can't tell you why it came back, because a post-op X-ray, if anything, was almost overcorrected. But by and large, I think if you do a good surgical fix, you get good anatomical congruency, that'll probably last a lifetime.
Mm.
Um, I try a lot harder on my 25-year-old because they're going to be around longer.
Yeah.
I can't say I've seen many 95-year-olds with recurrence because
Yeah.
they're not around as long as
Yeah.
that. Um, but yeah, recurrence is an issue for sure,
If
and
they
I
ask,
see it. Sorry, I see it in other surgeons, and there are, we all see each other's work, and we tend to sort of see other people's failures because if you had a bad result, if you've still got trust in that surgeon, you'll go back and see him. And I try really hard to keep trust in patients, and it's basically about being honest and authentic.
yeah.
And I'm not sure that's the case with all the surgeons I've got experience of in my area. So I'll see cases come from other surgeons come to see me for second opinions and revisions, and I'm almost never critical of any other surgeon because you know what? I wasn't there on the day. I
Mm.
don't know how that surgery went. I don't know about the relationship between the patient and that surgeon, even if I'm not the biggest fan of that surgeon and their skill set and their whole demeanor. It's my job just to kind of say, okay, we're here where we are now. It's my job to see if I can fix you and make you better.
Yeah.
Uh, and we do, I'd like to think surgeons would give me the same courtesy the other way around. That's not the case, sadly.
No.
There's some squabbling between surgeons and between professions. But you've just got to be kind of authentic and honest as much as you can.
How do you manage those conversations? The squabbling.
Um,
I think.
yeah, honesty and authenticity. I mean, I'll say, look, I wasn't there on the day. That doesn't seem to have worked out well. Here we are now, 2 years down the road, and you've got recurrent bunion. I mean, there are certainly times that I'll see if I've got access to all the X-rays. Say in an ideal world, are we talking about somebody who's come from St Elsewhere now, Ben? They've come
Yeah, yeah,
from
yeah, yeah,
down the
yeah.
road. Okay. On a good day, then I would have the pre-op X-rays, the post-op X-rays, and then the ones 2 years down the road. And I might be able to say, do you know what? It looked to be a little undercorrected on the day, if I'm honest.
Mm.
But I will say, but I wasn't there. I don't know how the case went because sometimes it just goes to shite.
Yeah.
And I don't know how compliant the patient was. I don't know because I've had patients that actually got an email from one yesterday
Yeah.
who took all her own bandages off after surgery and completely ruined my work within a month.
Uh,
And she was one of the local GPs who thought
um,
she knew better. So anybody that looks at that foot would see a recurrent bunion,
yeah.
who didn't know the story. But I'll say, look, I wasn't there, and I'm not going to criticize. And I'll say, look, I've had cases of mine that have looked like that. So we are where we are. I'll do what I can to fix it. What are your goals? Pain, function, cosmetics, whatever. And then I'll see, can I match my meager skill set with your goals?
Mm.
And if I can, then we'll jump in.
Yeah.
Um, and I've had some, and they're kind of nice when you do get to kind of get a, you revise somebody else's work, not in a kind of Schadenfreude kind of way. Or look at me, I was the big hero that came in. Is that you've got a patient that's had a suboptimal experience, and you want them to have a better experience the next time.
Yeah. Yeah. If they ask out of interest, is there anything I can do to reduce the risk or prevent it coming back? What can we say? Is there anything?
So if I've got, well, probably the biggest thing that I see out there in terms of recurrence is really kind of hypermobility. If I see what I refer to as a flobbery joint, then I think we need to look at doing joint destructive procedures. So fusions, be that fusing the big toe, which I think the average physio would go, oh my God, don't fuse the big toe. Fusing the big toe is a fabulous procedure. Fabulous. We love fusing big toes. Not everybody functions well on it, but if you can put the toe in a good position, those patients often do well in the long term. So if you fuse that big toe, it's a bit like my career. It's going nowhere. So that's probably kind of your gold standard for bad recurrent bunions. But of course, then you run the risk of non-union, which can be painful.
Yeah.
Gait disturbances because the big toe is a bit stiff now because it ain't not moving. Footwear fit issue. So you can swap one set of complications for another.
Yes. With potentially more, it sounds like what you were saying earlier, greater risk. Is that right?
Yeah.
More serious risk.
Because so I had a case. He'd had surgery at St Elsewhere. Wasn't thrilled with the result. Came through to me, and we had good instant rapport. I knew the surgeon who'd done his first surgery. He's a very good surgeon, very skilled. Just this particular case, he just got away from him, and patient wasn't happy with the long-term result, hence had kind of gone elsewhere. But because there was a lot of scar tissue, the patient had, when I did the revision surgery, so the revision went great, but he took 4 months to heal, just because of wound, the wound broke down, which I kind of managed, and so it really was a real case of managing that relationship, because he'd come through unhappy, and then effectively swapped one problem for another. Now he's healed in the last month or so, but that was 4 months of delayed wound healing. But because it was a second scar, there's lots of scar tissue. So just nobody would criticize that in terms of me. It's just bad luck. You're the second surgeon, lots of scar tissue. Actually, nice job of revising the previous surgery. But you had a patient at the centre of it. He was, he's the guy that matters most, and took a long while to sort of manage that kind of wound care really, and then got an infection in it, so we were dealing with a wound plus infection, and it's kind of but that's the job, you see these.
Now we talked about bunions.
Yep.
And the other thing I've got on our list was this, you mentioned hallux toes earlier. Now again, most people listening to this can picture a hallux toe.
Well, the hallux is the big toe, Ben.
Oh, sorry.
You mean hammer toes?
Hammer toes, sorry, yes.
Hammer toes.
Hammer toes.
Hammer toes being the condition, not the treatment. Can I just point that out?
Yes. So
A little joke there, as in we don't have.
we don't
I'm
hammer
going to
them.
send you these jokes on WhatsApp so you can read them first. So you know there's a joke coming. I'll give you a wink, and then you can laugh
At the right timing.
genuinely, if possible.
Well, again, if someone comes in with that toe, again, most people listening to this can picture the hammer toe,
Yeah, bendy joke.
but most people couldn't tell us more than that. So
Okay.
again, let's say Trisha, this time we'll swap a bunion for a hammer toe,
Yeah.
and she asks, "Why have I got this?"
Okay.
What should we say?
So a hammer toe is effectively a double bend. So a classic hammer toe bend is a hyperextension at the metatarsophalangeal joint and a plantar flexion at the proximal interphalangeal joint. So it's up, down, and then the distal interphalangeal joint can be straight or it can be Bunionier. as opposed to a mallet toe, which I can do with my forefinger, which is a distal interphalangeal flexion. You've then got claw, which is both bending plus or minus retraction. And then you can throw in the mix as well. You can throw in some transverse plane and you can throw in some frontal plane as well. So if you're saying hammer toes, you've actually got a real flavor of digital deformities. And they're all kind of different from toe to toe. But if you're saying, if you put me on the spot and say, what's the main thing? I'd have to go routine again and say probably overpronation is probably the biggest thing, in that when you're a little bit flat-footed, you tend to kind of claw the toes. And if you're a bit of a jaunty angle, it affects the pull of the long, particularly the long, but also the short flexors, and tends to bring the toes into flexion. So lots of old style pods like me would say flat-footedness, and then throw in shoes. If you've got long toes, they'll tend to buckle, or if you've got a short big toe, which is known as a Morton's toe. But yeah, probably pronation and shoes would probably be the big two there.
I'm picturing, and as you say, might not be the classic hammer. It might be off in different directions or certain positions. If someone's got it and they turn up to their healthcare person, they say, "I've
Yeah,
got this," and the
yeah,
person can see the deformity,
yeah,
but it's not causing them a problem
yeah,
as far as they're aware.
yeah.
What should we say?
Okay,
Given,
so you've got a bit of a bendy toe. The great that you're not getting any problems with it now. You might have in the future, but you might not. If you've got lots of instability around a joint, say you've got a plantar plate disruption, which is where a toe started to dislocate, then they will almost inevitably go on to completely sublux and become arthritic over time. So if I see that, it's fairly unusual. But I'll send to those patients, we need to do some treatment for that because it's going to get worse. But if you've got an amount of deformity and you wear sensible shoes, you may well get away with it. So, back when I was particularly a jobbing chiropodist back in my, that really kind of the first 10 years of my career, and I was doing lots of geriatric work, I would see lots of 70, 80, 90-year-olds who were coming through with lots of deformity, but primarily coming through for nail care effectively, and didn't have any problems with that deformity. And particularly lots of those patients who became less active and were sitting around the house wearing slippers, oftentimes were relatively asymptomatic. So you can't accurately predict that somebody's going to get problems in the future. You can maybe advise them in terms of kind of good footwear, sensible footwear. Maybe don't wear court shoes if you've got hammer toes.
is that the same for bunions as well?
Yeah, yeah. I mean, it's yeah. If I've got, I remember some of the. I mean, a couple of years out, I saw the flattest feet I ever saw in this 90-year-old. They were complete pest pancakers, massive bunion.
Yeah.
Never had a day's pain in her life because I actually said to her about a bunion. She said, "No, never hurt me at all." So it's not inevitable that with deformity you will get pain. So when you're seeing a patient, is what are their goals? Now, typically with me, I would want to have reduction of pain, or ideally elimination of pain, right at the top of the list. It hurts. I'd rather it didn't. Thank you very much. So that would be, if you had on like a pie chart, that would be 2/3 of my pie chart would be to reduce their pain, and then the other third would be function, cosmesis, footwear fit. If a patient wants to wear anything other than Crocs, for instance, if a patient wants to be more active, if a patient doesn't like the look of their foot, I totally get that. So it's really saying, what is it that you want me to do for you? And then it's, can I match my skill set with your goals? But I'd like to think the pain will be the biggest thing in there.
Yeah. I presume, would that be the main reason people turn up to your door? Because it hurts?
Yeah. Most of my patients are ouchy at some level.
And let's say, again, is it that when you're discussing surgery with them, an option to managing their hammer deformity of however position it's in,
Yeah,
again, is the risks pending on what you're planning on suggesting to them?
for sure. Yeah. So you can do relatively simple procedures where you just do like a little break and reset, or you can do soft tissue procedures. They heal fairly quickly. Or if you've got more of a complex procedure, you're looking to do a fusion of one of the interphalangeal joints with oftentimes soft tissue release, which might involve tenotomy, capsulotomies. You might be moving a toe down and round and across. So yeah, very, very much the risks are intended on the more you do, the bigger the risk profile. But if you don't correct the deformity, if you try and fudge it, then you may well see that patient back in 2 to 5 years with recurrence of deformities. So again, it's kind of a dealer's choice. It might be that with my more mature patient, I might do a less aggressive procedure. So, for instance, if I've got a 85-year-old whose circulation isn't fabulous and she's got a crossover toes like this, then I'm probably going to recommend amputation because it's a simple procedure. The toe's not going to grow back and they're going to heal pretty well because it's a simple cut. Whereas if I do, kind of super complex triplanar corrections of that digit, it's more invasive surgery, takes longer to heal, it can go pear-shaped, and you're more likely to have an unhappy patient. But in a 25-year-old, I want to give them a good long-term fix, which I think is going to stand the test of time, which will typically be hammer toe fusion with soft tissue augmentation as required. I'm not going to be amputating toes in a 25-year-old.
How does that conversation go with I'd say it sounds like predominantly a more elderly person?
Yeah, it's a bit predominant. So I give them the choice. I give them the choice. I say, look, we have got. I say choices. It's funny when we talk about informed consent. I read something really cute on informed consent. What did I read on the plane on the way over here? It was Adam Kay's "This Is Going to Hurt." Have you come across that book?
Yeah, I've read it a few years ago. Yeah, it's a great book.
Yeah, it was late to me. It was on my Kindle, and I had a kind of like a long flight over. And I thought I'm just going to read it. I read it in a day. It was brilliant, sad and unsettling in equal measure. But he had this thing about informed consent. Patients basically are supposed to have informed consent. And his view on that was they either take my advice or they don't, which I thought was a bit binary, but was kind of interesting, really. So in theory, I'm supposed to give patients all the options. Now, it could be for a hammer toe that there are 4 or 5 options. Now, I don't know how really you expect any patient given 4 or 5 options as a lay member of the public, given, I wouldn't know what I'd want if it was my toe, and I'm supposed to know what I'm talking about. So I'll absolutely give them the options, but I'm old-fashioned enough to say, but if it was my foot, this is what I'd have. Because you can't push them into doing it. You're supposed to give them the options, but I just don't think that really works. So I'll say to my little old lady, look, I can do A, B, or C, but if I were you, I'd have an amputation. And occasionally patients will say, well, I want this particular choice. And then I've got the decision, well, I do what I know is not in their best interest and give them the surgery that has the most risks? Or do I say, well, if you want that particular operation, that's fine, but I'm not going to do it because I don't want to be the one that causes you to have all the problems. You need to go and find somebody else, which I think I've had to do on occasion. Probably the times I'll turn somebody down for surgeries would be risk factors, which would be, so I've got a lady at the moment whose bloods are all over the shot. She's not going to heal after surgery. Hemoglobin's really low. Obviously, risk of infection, risk of thrombosis, falls risk. My little old lady comes through, staggering on 2 sticks, and needs to have flat foot correction, where you're going to be non-weight bearing for 6 weeks. It's not gonna fly. So there's times that I'll say fudge is probably not the right word. Compromise my surgical goals, and the best example of that would be amputation for a little old lady, because that's the best option for that patient, in my humble opinion, of 4,000 and counting hammer toes.
How do they react when you suggest amputation?
Yeah, there's normally a bit of an intake of breath, because it's a bit like, it normally comes as a bit of a bit of a shock, really, because it's quite a strong word, really. So you again, it's that trust, that it's all that authenticity of saying, look, these are your options. We can do this, but it's more likely going to fail if I do this heroic fix, or you can have 10 minutes in theatre, it's going to heal, and this is much more likely going to give you a good result.
Yeah.
But it's up to them. It's up to them. Yeah. But you might try and be a little bit persuasive. If I can get a 3-year-old to eat, cheese and broccoli, I can probably use some of that learned experience of being persuasive. But I don't do it in a Malkovekian way. I'm just wanting to get good results for patients because, at any one time I've got 3 or 4 patients I'm worried about and losing sleep about. I don't want that to be 10 patients, 15 patients. So I'm doing things in a slightly paternalistic, old-fashioned way because I'm an old guy,
Mm.
but I'm doing it with absolutely the best intentions.
Yeah,
Absolutely best intentions.
of course, of course. And do most take it when
Mm.
if you lay out the amputation? Yeah.
Yeah, yeah. And if they don't and they choose to go elsewhere, then that's probably a good fit because you want to have like a round peg in a round hole. You want the patient to think that they trust you, but equally, it's my reputation on the line with that patient as well. So you want that to be kind of like a kind of a good fit, really.
Mm.
That I'm doing the best for the patient, but the patient knows I'm doing the best for them. And um, I I say lost a patient who I'd given them a surgical plan and they'd gone to see somebody else who, how can I say this? We're being recorded. I'll say they differed in the opinion that gave to the patient. I'll speak about it offline. This is a practitioner that he and I need to have a conversation outside work
Mm.
um, next year um, because of some of that practitioner's style.
Mm.
But the patient now, I was giving them quite an aggressive surgical option to fix it. Person B was saying no, something less would do. And I think that patient is going to go with person B, which is absolutely fine because then she now trusts person B, and that's fine. If I had tried to talk to her into this, she actually needs an aggressive um, she got heel pain. She got really bad plantar fasciitis. So what she needs is I've done everything for her. What she needs is a plantar fascia release, which is quite a strong option because there's some downsides with that. Particularly, you can have lowering of the arch profile, which causes some calcaneal cuboid impingement. I've only seen it twice, but those patients are really troubled if that happens. But not that I'm going to, but if I try to kind of coax her back from person B, talk her into the surgery, and it fails, it's all on me.
Yeah, yeah.
What will probably happen is she'll spend 6 months with person B. That will all fail
Yeah.
because I've done everything for the last 2 years, and guess what? It's failed. Non-surgical options. I'm a surgeon, but I don't rush to surgery, so I'll do shockwave, injection therapy, orthotics, all that kind of stuff. And she'll probably come back and kind of go, "Yeah, do you know what? I will go for that plantar fascia release, and I'll do it. That'll probably work, and that'll all be good."
Yeah.
Where we are at the moment, she's been swayed by some of that.
Yeah, yeah, yeah. As you say, I've said to people in the past, sometimes it just needs to be the right time. Time for that
Absolutely.
person.
Yeah,
Um,
I'm in the business of making people better, Ben, genuinely.
mm,
I'm kind of busy. I don't need to kind of pinch patients from
mm,
other clinicians. Even if other clinicians choose to do that, that's on them.
mm.
I mean, I say I sleep well at night. I sleep well at night knowing that I try and do a good job. I lose sleep when patients don't have a good result, and sometimes that's on me. Sometimes that's just bad luck.
Yeah.
And I was having this conversation. There's one of the orthopods I have a really good relationship in one of my private hospitals. Lovely, lovely guy, really good surgeon, wonderful with patients, and we're on a very similar wavelength. And we were talking about this over coffee in between cases a couple of weeks ago. And we were talking about how we both lose sleep. And we're funny enough, we were kind of juniors together. And we kind of went and kind of came back into the hospital like 20 years later, having gone different ways and come back. Lovely, lovely guy. And um, we were both saying that in some ways we feel we've got it wrong in that we're the ones that lose sleep at night when we know not all of our colleagues do. But
Mm.
we also were happy that we're the sort of guys that lose sleep at night because we feel that we're still in it for the right reasons. And you can't change your personality, but we've made peace with our softness, for want of.
Someone, someone's seen it calls it human skills. I think that describes
Yeah,
it best.
yeah, yeah, yeah. What do they call it? What do they call it? It's got a term, hasn't it? Is it NOTS? Non operative technical skills for surgeons, or it's got some kind of
Ah, okay, okay.
there is I mean, and the Royal College of Surgeons have been brilliant on this. Really, within surgery, I can't remember if we recorded this. No, I don't think this. We were chatting before that. Kind of when I went into chiropody, I was a B stream student. Probably could have been an A if I'd put my mind to it. in that, I have a doctorate now, so clearly I can, put my mind to it if I kind of wanted to. But at the time, I was a B stream student because that's all I needed to become a chiropodist. But the Royal College of Surgeons and that sort of the higher echelon of surgical teaching, they've done an awful lot of working on that. So the guys who I went to sixth form college with, who were the straight A students who went into medicine. So not all of those necessarily, while being wildly intelligent, would always necessarily make the best clinicians and people,
Yeah. Mm.
while being, jolly clever and learning to sort of that, what they used to call the knowledge burden, just knowing all that kind of medicine stuff.
Yeah.
And they've done an awful lot within sort of medicine and surgery to work on people skills to augment technical skills. So it's there's lots of really good quotes in surgery, and I do love them. It's like it takes 20 years to learn how to become a surgeon, and another 30 knowing when not to operate. Cliches like that. The best time to operate is when you don't operate at all, because you look at cases and it's oftentimes your own experience is my favorite. Experience is what you get when you don't get what you wanted. So you see a case come through and you go, God, I had a case like this 10 years ago that went to shit, so I'm not going to do it again, because you learn from that. Hopefully you do at least. And they said that the Royal College of Surgeons does some really good work on these kind of non-technical skills for surgeons. I think it's NOTS, but I'd have to check that acronym, but that sort of thing,
Interesting.
And things like not being a major arsehole in theatre, and those days have gone. But I'm aware of some surgeons. I've had my moments of because it's kind of stressful doing the surgery, of being you're too young to remember the Sir Lancelot Sprat, but if you remember the old Carry On films that you may have seen by accident from youth, it was was it James Robertson Justice, that old 6'2" bully of a surgeon. And I've certainly known those guys, even within podiatric surgery. I've certainly known them within the medical surgical specialties, and maybe sort of technically brilliant, but not good people to work with and to work for. And it's all very well and good being technically good at what you do, but there's so much more to it than that.
You say those days are gone behind us, you think?
Mostly.
What do you put that down to? The fact that those days are mostly behind us now?
Combination of well, I was in the day, certainly when I was entering healthcare, there was still the kind of the doctor knows best. So people would just trust, particularly the doctor. And I think, certainly some of the medics at that time were brilliant. I'll give an example. Is one of he retired about 5 years ago. One of the orthopods that I knew really well in one of my local private hospitals. I shouldn't give a name drop, but he was proper old school gent, slightly sort of like probably lower upper class or upper middle class, really well spoken, brilliant surgeon. Everybody had just nice things to say about him. And I remember being in the changing room, and we were talking about a particularly rare form of foot infection, a schistosomiasis, which is a really rare sort of like sub-Saharan African infection on a patient that I was my old boss had managed. And we were talking about this case, and he just literally overheard it, and just as if he was reading from a textbook, talked about the different forms of that infection, which he probably not read in a book or thought about for probably 30 years. And just that proper intelligent old-fashioned doctor. And I was just so impressed with that. I just thought, wow, you're that sort of guy that I would trust. Brilliant, heightened intelligence, great surgeon, everything about him, we just looked up to. But he was of a day, and those guys have kind of mostly retired now, that particular subset. And then the internet. So you obviously get that situation, Ben. I know you've had it. People come through, they Google their own symptoms. So the information's out there to people in a way that it wasn't before. So you've got some of that straight A student medic type that have gone. You've got more people, doctors now, but those Sir Lancelot Sprats have kind of gone and retired off. the information's out there, and also people don't put up with that kind of crapola now that that you can be talked to as if somehow the doctor's doing you a favor by deigning to treat you. People don't put up with that kind of being treated as a patient. They're more of a client and a consumer now. So I think all those factors really kind of merge into sort of doctor knows best days have gone really, and just being a kind of like a bit of a arsehole in theatre. And there's still those guys kind of out there, but they're certainly less and less now. And they over the years were combated by the senior matron, who was equally fearsome in her own way, and would keep those docs in order. And certainly I can think of when I was junior coming up through the ranks, being completely battered by the senior nurse in theatre, and not always done nicely, not always pleasant at all.
Yeah.
But you actually learn from that experience. When you sort of put your hand in the wrong place or drop the instrument or sewed somebody up wrong, you were told. But that style of teaching's gone now. You've got to be a little bit more nurturing. So mostly it's gone. Mostly.
I have interest. In physio, we have it. Generally, the more rapport you have with your patient or trust as well, the better the outcomes on average. Is it the same in podiatric surgery as well?
Yeah. Same in all surgery. There's that, and interestingly, the results show that female surgeons get the better results because they're generally better people. Hopefully, that's not me being a bit, what's the word I'm looking for? Gender neutral? No. What's the word? Virtue signaling. But the evidence is strongly there that the female surgeons are just better.
Yeah.
Just across the board, and yet. You look within orthopedic surgery, say, what is it, 3% of orthopedic surgeons are female?
Really?
Interesting. And yet, what is it, 60, 70, 80% of medical students female?
Really? Wow. Do you know why that is, out of interest?
I think within surgery, I think it's still a little bit of a male bastion. I think it's similar numbers within pod surgery. I think it tends to appeal more to that kind of fix it mentality. I'm very much a fixer. If I'd gone into medicine, then I wouldn't be in one of those specialties where I would sit and spend an hour talking to you and nurture your problems. Let's say like psychiatry or internal medicine. That's not me. You've got a problem, okay, I can fix it. Okay, thank you. Fix, goodbye. So that I think appeals to the blokes. Whether there's an issue with, because typically, I think I'm right in saying it's normally still the females that have the babies, although. What is it as a woman? Is it anybody that identifies as a woman? So, okay, let's say a person with a uterus, generally they generally are women and they generally have the babies, and that generally is a bit of a career break issue.
Yeah.
So, you'll see more females in, general practice and anesthesiology, I think, where they're a little bit more family-friendly specialties, but I'm straying out of my lane now. I don't want to say anything controversial, but
No, it's fine. I don't think that's controversial at all.
you can offend anybody. It's amazing how people will seek to take offence.
Yeah. Those people that, as you say, patients can Google their problems, can Google their options.
Yeah.
And as you said earlier, actually, it comes with the experience of knowing when not to operate.
Yeah.
I'm just picturing, before we get to your hardest conversation, the person who comes in with some form of foot deformity condition that you could potentially treat.
Yeah.
But whether it's for another medical reason or just some experience or whatever it is, you feel actually surgery is not a good idea in this situation.
Yeah.
How, again, should people have those conversations about surgery is not in their best interest?
So I like to use, so when you've got patients come through with a set of ideas and a set of wants, then, there's ways you can kind of manage that. You can kind of go straight back at them, which will often lead to kind of conflict because they'll often come through with, problems, anxieties, goals, and my job is to meet them, and most times I can try to do that. I will often have a bit of a flanking maneuver, and I'll use humor a lot to kind of keep things light and empathetic. So I'll say somebody comes through, so I read on Google that, and I'll say, oh, you're already under Dr. Google. Well, I can't see you if you're already under the care of another physician. And you'll get patients come through and say, look, I've Googled my symptoms, I've got this. And I go, actually, no, you've got this. And then you've got to kind of completely say, this is all wrong that you've read. This is not your thing. It's this.
Yeah.
Um, but no, a lot of the time patients come through with a problem, and surgery isn't necessarily the best idea, or certainly isn't the first idea. So I get a lot of heel pain come through. I get patients that come through with plantar fasciitis, but I see a lot of heel pain and actually run heel pain courses. So I can, given time and a pad and paper, I can give you 30 different causes of heel pain. Now, most of the time it is plantar fasciitis for sure, but oftentimes it's not, or it's a mixed pathology. So it might be that somebody, but even somebody comes through with a kind of straight plantar fasciitis, and it might be that you can fix it with surgery. Yeah, but surgery is kind of like the top rung of a ladder. And I say to patients, look, there's surgery. Here is weight loss, physio, injection. It's like going one rung at a ladder. You don't go straight to the top rung.
Yeah.
So I'll give them the options and say, probably for most things I see, Ben, there's a conservative approach to their management of their pathology. There would be some form of, say, injection therapy or some form of intervention, minor order, and then there's surgery. And broadly, you'll go conservative, say injection therapy. I do a lot of injection therapy, and then surgery. You might mix that up a little bit. You might go straight in with plantar fasciitis. I'll often go straight in with an injection and then do other things. But I'll try and give people the options, and they might say, but I want to get it fixed and go straight to surgery. And that probably isn't in their best interest. So you'll then sort of say, okay, I've given you the options, but let's try this first. Because if we go straight to surgery and this happens and you're worse off, then you're worse off and I can't fix that. If I do a fascia release and then you get a lowered arch profile, flat foot and calcaneal cuboid impingement, then you're going to need major surgery that might put that right. And done it twice, and I remember both those patients. But that's part of, I think, the patient management. Because so next year it'll be my 40th year in the profession if you include my undergraduates, and that's quite a few patient consultations. So you get relatively good at weighing up the patient and how the consultation would go, and it's what they want really. And if I'm not that guy, then I'll step aside and say, yeah, you need this. That's me. This is what you need.
Before we get into your hardest conversation, were there other things around communicating with bunions or toe deformities that you wanted to say that we've missed?
Oh, well, it's really all about what is it the patient wants. From my perspective, as a kind of a bunion fixer, what is it? What are their goals? And I get them to really point it out. Is it pain? Is it function? Is it cosmesis? Is it footwear? And then you kind of work to say, can I meet that? And that's very much part of the consenting process. And the tricky side is when things then you're losing that conversation. You have these kind of divergent tracks. The patient, well, this is what I want and this is what I can do for them. And if that happens after surgery, you're a little bit committed. Yeah, bunions, that's probably, although I've done more hammer toes than bunions, because there'll be times I'll do 3 or even 8 hammer toes on a patient at one sitting, obviously one bunion. Bunions is probably my biggest referral pathology that I see. So I would probably style myself as a kind of like a bunion fixer.
Right. Well, you knew this bit was coming, and I'll ask everyone this. So, whether it's related to surgery or whether it's people in the past, Ian, what has been your hardest clinical conversation?
Well, so if I say that 10% of my patients have a complication, which can be immediate post-op pain, bleeding, post-op nausea and vomiting, all the way through to chronic pain. So I've had 2 patients I've caused complex regional pain syndrome on, and then a slew of non-healing wounds and fractures. So you'll see a range of complications. Most people eventually will get there, but you will end up with some patients who just have a really bad outcome. And I've been on the wrong end of a number of medical legal lawsuits, and that happens in our world. It happens a lot in the pod surgery world, particularly if patients go off and see other surgical specialties. So I do quite a bit of medical legal work myself. So I've been doing that for nearly 20 years. And so I can say every single most of the work that I do in terms of medical legal work, I do defending pod surgeons that get themselves down a rabbit hole of being sued.
Mm.
Every single case, so 80% of my work is for the defendant, 20% for the claimant. Every single case where I've acted for a defendant, I as a pod surgeon, every single case has been, bar one or two, has been a standard surgical complication, nothing negligent, bar one or two.
Mm.
And I'm talking dozens of cases, Ben, where that patient saw an orthopedic surgeon and then a case arose. Now, I'm not saying that it's because they saw an orthopedic surgeon that the patient was encouraged to sue. I'm just saying every single case that I've defended saw an orthopedic surgeon for a second opinion, and then a legal case ensued. So, and of the cases against me, that's been with me. Of the number of times I've been sued, every time my patient has had a complication that was, in my opinion, non-negligent, just things that happen, fracture, infection, etc. Stuff happens. You don't always do the best work, but there's a point where you go, that didn't go great, that was negligent. It's a continuum, and I guess it leads on to those are the really difficult conversations. When you get a patient then that has had a bad outcome, is unhappy, justifiably unhappy, if they have, let's have a think, recurrent bunion or a fracture or pain, and they're living with pain every day.
Yeah.
But I had a case last year, and it's ironic, really. You know, I mentioned the case of the wound care issue that I had. So I had a patient had this surgery. The toe had gone into a poor position after surgery, needed to revise. I did the revision, patient's happy, but I had a wound care problem and managed that, and that's all fine. Exactly that case, in terms of exactly the same procedure, where I'd had the toe went into a not perfect position. And the patient in question had a experience with another surgeon, and had gone from being unhappy with me to being extremely unhappy and angry. And when I saw what was written about my care from another surgeon, I was, well, various emotions kind of come to mind, really. It wasn't representative of the care that I'd offered this patient. I'd done a good job for the patient. Sometimes stuff happens. And you then obviously, you then have to deal with that. So I had a very, very uncomfortable consultation with that patient afterwards. And, didn't need to be. It didn't need to be. So the patient that I operated on 4 months ago, it was a case of, oh, the toe's there. Do you know what? It's going to take me 10 minutes to do that. And it took me 10 minutes to do that. But I had to manage a very difficult consultation with a patient who had been, wound up unnecessarily.
Yeah.
And yeah, it's just very personal.
Yeah.
And
how does one decompress after that? Because obviously, if someone's coming in with a lot of emotions aimed at you, and I presume, was this potentially the last person today, or was there people after them that you still had to support, treat or assess potentially?
oh yeah, absolutely. This was this was halfway through a busy clinic.
Right.
So I'd seen about half a dozen patients, and then had to meet this woman
Mm.
and her husband and the hospital manager, and have this consultation, and then do the rest of the day. So yeah, and this was 18 months ago, and I still first off have concern for the patient, because she didn't have the best result after my surgery. She's had that surgery done actually at St Elsewhere for various reasons. And just a few weeks ago, I asked, because I know the surgeon, asked how she was doing, and all is good, which is great, because ultimately there's a patient in the middle of this, Ben.
Yeah.
I think what's just difficult is just it's so anti-Hippocratic to
Mm.
um, use that experience to be, well, unprofessional, for want of a better term, really. It's a kind of a tough pill to swallow. And this was 18 months ago, and you can see I'm still not over it.
Wow. How did you kind of get, you got to see people after them, and you then got to go home to a family. Um, how did you try and, well,
That's the
we're all
job,
looking,
Ben. This,
yeah.
this, this, this is the job. So, I've gone from being a job in chiropodies, cutting toenails, to doing surgery. It's a tough gig. It's made harder when you get these kind of interprofessional rivalries. And it's not unique with podiatric surgeon and other members of the surgical community. You get rivalries within, there are lots of areas in medicine where there can be crossovers, and you can have two people in the same profession not get on, within a team. That happens where people don't get on. Um, but ultimately, that's kind of the job. It's a tough job. It's difficult when people make it harder than it needs to be, but that's the job. And on any day, you can have somebody that's had a bad result. On my last clinic before Christmas, I had four patients who'd had problems through the year, literally on my last day, within a 90-minute period. And you talk about heart sinkers, you look at them kind of, oh my crumbs, they've all coming back today. Thankfully, three of the four were doing really well. It was like really good consultations. And one, there's a little bit of work to do. But that's the job. And ultimately, if you're going to kind of move from being a therapist as a
Mm.
chiropodist, if you like, and move into the world of surgery, you kind of have to go, well, that's the job. If it's a bit too hot for you, then get out of the kitchen.
Yeah.
But yeah, it's not easy. And if I had a less caring personality, I would sleep better at night. But I'm okay with that.
And again, I said this earlier, this is one of the underappreciated parts of when people, non-surgeons, thinking about surgery, just all the things that come with it that isn't the surgery bit, but it's all the other, the risks, the responsibilities, etc. Um, that is, I guess you called it earlier, the non-operative skills part, right?
Mhm.
Um, and thank you for sharing that, because it's important for people to know that it's not everything goes smoothly. But as you say, many do.
Most do, yeah, and the rewards of doing surgery are amazing. One of the questions I know you're going to ask, so I'll answer it before you ask it.
Go on.
Is one of your best results? Now, to be fair, I must have got this year 20 bottles of wine, 30 boxes of chocolates,
Yeah.
all sorts of presents for patients. It's hugely rewarding because most patients do well, and you take patients who are in kind of chronic pain and you can fix them in a way that it's probably difficult to do outside of surgery. I'm not saying you don't fix them in physio at all. The rewards are great, and I love it. And there's the technical side of the job, which is just fun to do surgery. It's just a joy to do what you do, and most people get better, and it's amazing, Ben. But probably the best case that I can remember in years ago was a few years ago now was a young girl. She was 14 years old with really bad verrucas,
Okay.
and she was child of a rather bad divorce. Had a very caring but warring set of patients. So she was in the middle of this because one time I had mum, one time I had dad, and they didn't speak. And she was this um, covered in verrucas, 14-year-old going through puberty and wouldn't do sports because she couldn't get in the showers because she had like 20 verrucas on both feet. And I did some of my kind of like, magic stuff. I managed to get all the verrucas to go. And I cannot tell you what a psychological effect it had on that 14-year-old girl. And also from the father, who's a really lovely, caring father, who kind of came through and was paying me cash for this particular treatment I was doing. And honestly, although I made a couple of quid on it,
Mm.
I'd have done it for free because the impact it had on that girl's psychology was immeasurable. And it was just humbling to just be that little, you know, agent for change, when she was having tough time at home, tough time at school, tough time puberty. I mean, 14-year old is tough time for anybody. And
Yeah.
just that she just was a totally different person when she came through with beautiful verruca skin feet. And kind of like the bottom end of what I do professionally, but just probably the most memorable. And you forget the bunions that go well because that happens on a daily day basis, and you get nice letters, and it's great. And I audit all the work I do as well, so
Mm.
all the patients have a pre-op, so you get all this feedback. But it's those kind of standout moments that you think, that's priceless. Really, it is.
Yeah. It's the kind of the bigger effect beyond just what's happened at the foot, so to speak.
Just so, absolutely.
Yeah. Can I ask you about one more surgery
Of course,
actually? Because
absolutely, yeah,
and I was talking about satisfying surgeries, and I think you have a YouTube channel, you have a Twitter, there's an Instagram.
yeah. Ah,
Uh,
you've been looking. Okay.
so the YouTube channel, from what I can gather, the most watched ones are essentially these cysts that pop like
Yeah, yeah, yeah.
spots, essentially. Is it, being the surgeon there, is it as satisfying had to see that cyst pop essentially as it is for people watching it?
Yeah, you make out that I'm some kind of whack job if I like doing them. Yeah, I hate doing those. Yeah, yeah, they're so cool. They're so cool to do.
Um, so, and again, thank you for doing this, Ian, because
Welcome, mate.
it's I've by far the one I've learned the most off of speaking to anyone. I've said about, so there's
That
Instagram.
doesn't necessarily mean I was a good guess. I'm sorry about that. It just
You
means you
were,
had a
you
really
were.
bad guess in the past. So I say that. No, you had oh come, who's your physio injector guy? You
Nick.
had Nick.
Yeah.
So I've not met Nick, but I've done one of Nick's courses. I've got such a respect for Nick. I hope you're watching this. Love what Nick's done within physio and injection therapy. I love his style. And you know, I think I need to be a bit more professional like Nick. I love what Nick's doing. So yeah, I've watched a couple of your videos. Lovely style, actually, Ben. I
Thank
like the
you.
way you
Thank
kind
you.
of obviously I've not let you get much of a word in edgeways tonight. Apologies about that.
No, it's all right. No, it's that's how this works.
I
I
told you afterwards.
mean,
It shut me up. I did say.
and actually, you're not the only person like Nick. Nick, as we record this, and this may, because this episode's going to come out in the new year. Nick is the most downloaded of all the guests. So clearly, many people like Nick as
Yeah, he's
well.
got great knowledge. He's got great. What I like about what Nick's doing. So I'm probably most known within my profession as probably the main teacher of injection therapy
Mm.
for pods, and I try and do it in a similar way to Nick in terms of I love what I do, and I think it's great, but I'm not one of those people that just kind of goes do this because it works. Because it's that same sort of rationale is the same reason people think acupuncture works, which of course it doesn't, does it?
Depends who you ask.
Well, anybody that's read the evidence, apart from a mild effect on lower back pain, I'm being deliberately controversial there now, but genuinely, is we all fall into this, hey, this works for me. And so what I think I like about Nick, although I do think acupuncture is pretty flawed, really. However, what I like about Nick is his style, his knowledge. He's got a really good academic base, but also he's given that evidence base. He's not kind of going, "Hey, this works for me." I pick on acupuncture just to be sort of controversial, and then I've just remembered that you've probably got about 3,000 physios who do acupuncture.
No,
But
most of them would agree with you, I think.
yeah, I think so. I would. So I read. Somebody bought it for me years ago. Trick or treatment. Have you come across it, Ben?
Oh, it rings a bell.
Ernst.
Remind me.
So Edward Ernst, so he was an
Yes.
ex-homeopath scientist, teamed up with some kind of like proper scientist, and he basically had a look at um, complementary medicine. He had like a whole chapter on acupuncture, and he really kind of went through. Okay, it's 15 years old. This book, 2007, 2008, and I think obviously the people have done more science still, but he really kind of went through and looked at the evidence base for acupuncture with a very because he had a background in CAM, so from a very neutral but honestly openly critical view, just kind of go, most of the research is just not there. And if you get people who do, hey, I've treated 10 patients with acupuncture and they all got better. That's not science. But the same could be said within my world for podiatrists who do reflexology, who I've got a major problem with. It's just like it's just a foot massage. It does nothing
Mm.
beyond listening to people and actually being nice and spending an hour with them and people not seeing beyond the weakness of their own argument. So I try and do that, bringing it back to me with injection therapy and say, look, I really think injection therapy is brilliant for the right patient, but here's the evidence based.
Mm.
And Nick
Yeah,
does the same.
yeah, yeah. There's courses you mentioned. So you got the injection one. You told me
Yeah.
earlier. There's a dermatology one. There's gonna be a neurology one. obviously some surgery ones.
Yeah.
Where do people find all these courses?
Great question. So I put a few on my website, podsurgeon.co.uk. I'm not very good at updating it, but so every year I do once or twice my injection therapy course. I do my skin surgery course with my good friend Belinda. But it's mostly I'll do to, podiatrists. We've not had any physios on the course yet, although we nearly did a couple of years ago. They'd be very welcome. But yeah, it's kind of one of my kind of income streams really. Is I think last year I did about 17 days teaching. So bear in mind I do 60 hours a week,
Yeah.
included in that, I'll do one weekend a month operating and typically one weekend a month teaching. So I try and then I'll run some weekend courses in a couple of days here and there. So yeah, do between 50 and 20 days teaching a year, which I'd love to do them. Some online, some through the power of Zoom.
Yeah.
So I've done a nail surgery update for 500 podiatrists a couple of years ago during the pandemic. That was fun to do.
All over Zoom.
Yeah, yeah, yeah. Death by PowerPoint. But some courses lend themselves to, PowerPoint. Obviously, some are a bit more face to face.
I presume these courses, if it doesn't just podiatrist, but like a doctor, surgery, anyone could come in theory.
Oh, yeah, absolutely. Oh, yeah, absolutely. Yeah, it's actually would be lovely to get, more people coming from their backgrounds. And I kind of like to be challenged when I'm teaching as well, because I'll be controversial. I'll say something about acupuncture to get kind of a glib laugh. But I actually like it when people push back because then I've got to be, well, actually, I've looked at the evidence and blah, blah, blah. And I've tried. So actually the neurology course I'm going to run next year, I'm actually running with a doctor. So he's actually kind of headhunted me. He's married to a podiatrist and he wants to get into teaching. So we've sort of said, okay, that'd be great. What can we both work on where there's an overlap between medicine and podiatry? And we're going to start with neurology. Um, but equally, injection therapy, great to have some physios on it. I've tried to engage with a couple of docs. Certainly when I've done my injection therapy course, I've had rheumatologists on that, do some teaching, orthopods, do some teaching with me as well. Because, we're really bad though in podiatry being interdisciplinary. We're actually quite bunkered down. We'll often kind of be in our own little clinics and we're probably the worst at integrating with other areas of healthcare and medicine particularly. But, I'm still trying to get over my natural shyness. So if people want to come on a course, you're very welcome.
So we've got the courses, obviously the social media I've said. Are there other things you'd like to plug or mention?
Oh, heck, put me on the spot there now. No, but I not particularly. I mean, I've got a research basis as well. So if you found me on, I've got an ORCID profile, which is obviously the sort of the top end one or ResearchGate. So I've got a few publications out there based on, well, actually it covers a range of foot things really. So I think a little bit like Nick, who's got a research profile, trying to walk the walk really. It's not good enough to kind of say, hey, look, I've read the evidence, but also to kind of contribute to that evidence base to be a bit more of a credible researcher. So having danced around doing sort of higher degrees a few years ago, I finally kind of plucked up the courage and jumped on a doctorate in, when was it, 2019. So that was 5 years, finished it last year. So that was 5 years of my life, which was hard slog. Didn't do a PhD, I did a prof doctor because that kind of suited my track a little bit better. But I think I've got a kind of a credible research profile where I can say, yeah, I actually have a grounding in research theory and academia, and say, yeah, then in some small way I've kind of contributed in a small way to the evidence base. So I'm not just saying, hey, this is what I did for 2,000 patients and I think it works, because I don't think that's good enough anymore.
No, no.
I'm all over the socials.
Exactly. And I'm also in the description of this, below the timestamps, there will be every social media account, the YouTube with including the cyst popping one.
And the
And
really bad joke, so apologies for that.
it's grand. Thank you, Ian. This has been great, and it's just opened up a door and things that I think most people listening to this wouldn't have thought of before.
And you've got an email to forward on the complaints for some of the controversial
Oh, yeah,
stuff.
yeah,
Are
it's
you
fine.
gonna filter those out first?
Yeah, yeah.